Uh, love it. Well, Brandy, thank you so much just for coming and talking to us today. We just got connected recently, and then it's fun. We hopefully will get to meet on April 4th at our event we're doing with Spruce. So fun that you get to partner with us for that. And yeah, she was willing to come and kind of share with us as therapists, some things we might not be thinking about. And so, yeah, the floor is all yours, Brandy.
Well, thanks so much, Rachel. How much time do I have today? Because I don't want to steal all
Yeah,
of your time.
perfect. We need to be a hard stop by noon.
Okay.
Mhm.
I don't know if I'll go that long, but we'll see.
That's great. Yeah, that's fine. Use the time that makes sense.
Well, hey everybody, it's so good to meet you. Um, my name is Brandy. I'm a dietitian coming up on 8 years now, and I work at a company called Rooted Path Nutrition and Eating Disorders, which is actually a umbrella sister company, whatever you want to call it, underneath Starkle Nutrition, which has been around, I think, for closer to 10 years, maybe since 2007.
Mhm.
So not quite 10 years, I guess. Anyways, and we put together a little presentation on eating disorders just because we know that our medical communities need a little bit more support in this very niched area. I was so happy when I talked to Rachel about that some of you guys do eating disorders, which is awesome. And so hopefully I can share something new, or maybe you have questions or things like that that you would want your peers to know more about, and you could help me educate here. Um, I've worked at Center for Discovery. I still work there per diem. I worked there for about 2 years full time, and then started to kind of back out as I went more towards outpatient, which was my passion before. I took a break from private practice and contracting for a while to learn eating disorders, just seeing such a huge influx of people asking for that support. And I did not have the experience nor the bandwidth to try and learn something like that while doing private practice. And so took that break, went and got my education and training and supervision, and I'm kind of working my way back into this space again. But yeah, super passionate about eating disorders and disordered eating just in general. And yeah, excited to talk with you all about that as well. So I would actually love to hear from each of you. Shannon, I know has some experience, but maybe you could rate from like 1 to 10 what your experience is like with eating disorders, and if you have any like immediate thoughts or questions of things that you're hoping to learn today.
I'm happy to share. I can start. So the 10 scale, like scale is interesting. I'm trying to think. I feel like experience-wise, I mean, I do treat people with eating disorders, so maybe like an 8 or 9 out of 10 is like from my familiarity level with it. And I actually love the trainings for that Center Discovery offers. Cyber Discovery, I actually engage in those quite often. And I think today I'm just really curious to hear about, I guess, about your experience in general, but if there's any way you could cover some information about like if there's any apps. I know a lot of my clients use like recovery records and stuff like that.
Mhm.
So if there's anything you have, any like opinions you have about that. And then I know Ozempic, we talked even about this. Ozempic has been like a kind of hot topic lately. So I don't know if there's time to cover that, if it might be too adjacent or too tangential, but that'd be kind of interesting too.
Nice. That's fun.
Or oh, such great questions. I love that topic of Ozempic. So you could get me talking about that for a very long time.
Okay, good. I know that a question that came up from someone that's going to watch the recording is they're not as familiar with eating disorders, something kind of they're really learning a lot about, and are curious about, when they start kind of suspecting that there's eating disorder behavior or disorder, something is feeling like, oh, they're having more questions, and they're getting to a point where they're kind of trying to assess severity. Do you have specific tools or certain questions that you kind of tend to ask? And are there any, great ways that you found people can then help suggest additional support outside of therapy, and then kind of what does that tend to look like? If someone was to come to Rooted Path, for example, what is kind of those first appointments like so that the therapist can help prepare the client?
Great question. Okay. Amanda, your name and face looks so familiar. Did I
I
interview
was gonna
you?
say, I worked at CFD, so we probably have like seen each other's names on documents or so. Yeah. So yeah, my experience around eating disorder work, I would also say is like a 9 out of 10. Still actively working with outpatient folks on eating disorders. So I guess I would love to hear, like, from your experience on the outpatient level, like what that coordination between client, therapist, and dietitian can kind of look like. I have quite a few folks who I would really want to start working with a dietitian, and yet maybe like aren't ready, or, have a lot of hesitation around that. So maybe even like some like selling points of like why, a therapist is different from a dietitian, and why that's like really important in early eating disorder recovery work.
Love it.
Hi, Brandy. My name is Lily. I actually don't see anyone who is coming to therapy for the treatment of an eating disorder, but I just find more and more that the people I work with are experiencing disordered eating and don't know that that's what's happening for them. So I guess I'm just really excited to kind of hear today, to learn today. But I'm also curious how you might bring that into the conversation, how you might bring maybe diet culture and breaking down some of the pieces of it into a conversation when people really they're not really interested. My clients are not interested in that. So I'm very gentle with it. But yeah, that's my curiosity today, if that makes sense.
Absolutely. Thank you.
Hi, I'm like Lily. I don't have a lot of questions or anything like that. I just wanted to really learn. I do have a few clients that, talk about their weight and exercise, or somebody systemically is like telling them to lose weight and this and that and all that stuff. Which I mean, I, you know, in a healthier way. We want everybody to be healthy, right? So I'm just here to learn about this topic I don't know anything about, and yeah, and see where I can provide my clients any sort of help if it comes up.
Awesome. Thanks, Avisha. All right. Any other thoughts?
We've talked a little bit, but yeah, my primary focus is eating disorders. So this is kind of my world, and done it at PHP, IOP level, and now in outpatient, which is refreshing. I think if you've been in higher level care, it feels really nice to not be.
Oh.
But I think I'm just excited to have this conversation brought into our team and to hear it from a dietitian perspective. Yeah, I'm just looking forward to hearing, because it's such a vital part, that the dietitian part of working with the eating disorders is so vital and so significant. So I'm excited to hear, kind of like, have a whole team here, like, this is what this can look like and how it can benefit our clients. I think I'm also thinking about, curious about how you work with your clients around weight stigma and weight bias, and what that might look like for our clients as well.
Sure.
Mm-hmm.
Amazing. All right. Well, I'm going to share my screen here, and we will do the basics. This is the basics PowerPoint here. And then we will definitely, as we go along or at the end, whatever happens, we will get to all of the fun, maybe more nuanced stuff. Okay, so I think one of the things that came up, maybe not from the person here, but maybe the one that's going to watch the recording, right, was kind of this difference of like, how do I know if I'm seeing some behaviors, right, or I'm seeing something that just doesn't feel right? So there is a difference between disordered eating versus eating disorders. The disordered eating will always play into eating disorders, but the eating disorders does not always mean that it's disordered eating. And if you can untangle my words there. So there's always going to be disordered eating with eating disorders. There's going to be some unhealthy eating patterns that we can recognize, maybe restricting major food groups, like they've cut out all carbs and they're going to do keto, right? or maybe they're limiting their fats, things like that. There's some inflexibility or rigidity with the eating. Maybe they only eat during certain times of the day and they have to fast for 12 hours exactly, or something like that. There's certain portions that they go by, maybe exactly what's based off of the package for the serving size or things like that. And they're unable to tune into their own cues for what they're hungry for, maybe stopping when they're full, or they're unable to satisfy maybe the craving without feeling this guilt, things like that. So they only plate a little bit at a time. There is some stress or difficult emotions, just like the guilt. There can be shame with eating, especially when someone is in maybe a very limited or restricting pattern and they break that, right? They eat the Pop-Tart or whatever it was that they were trying to avoid. And there could be a lot of distress and anxiety that comes with that, which is maybe what you're sometimes hearing in session 2 is, oh my God, I can't lose weight. I just keep going back to these other foods. And we can hear the anxiety and sometimes the depression that comes out of talking about food and body weight. There could be some just all out calorie restriction, right? Like following MyFitnessPal and counting calories in there, things like that. We might see binge eating. We might see some purging irregularly, or even just some strong urges to purge as maybe a way to control weight. But as we'll talk about in a minute, has to meet some specific criteria in the DSM-5 to make a diagnosis of bulimia or something like that. We see a lot of dissatisfaction in bodies. It doesn't really matter if you have full-on eating disorder or not. If you live in the United States or in a Western country, we're going to see some kind of body image distress, right? Or even dysmorphia. And then the last one that I find is super big with just regular old disordered eating is we have categories of foods. We've got good and bad foods, healthy or unhealthy, clean or dirty, right? We see these kind of classifications of what a food is. And then there's the shame or the guilt that comes up with engaging with the bad foods. So take all of that and mush it into eating disorders as well, but like times it by 100. So we've got really obsessive thoughts about food. We're taking 5 or more hours of our brain space and our time in the day to think about food. Maybe they are, menu planning to the extreme and taking all of this time to cook and prep or only organic things, things like that. Maybe just having really obsessive thoughts about body and spending hours in front of the mirror or changing their clothes 20 times in the day because something doesn't look right. The thoughts become really obsessive and it's detracting from life, basically. There can be an extreme fear of gaining weight, right? Or becoming, quote, unhealthy. And this is maybe where that weight stigma piece comes in, right? Is we are told that you have to be a certain BMI in this very narrow range to be healthy. And even for someone in a smaller body, there's that internal weight stigma piece not experienced right by, someone in a larger body experiences the external, the worldwide systemic weight stigma, but somebody in a smaller body can still experience that internal weight stigma and the fear of becoming larger. And so it's to the point though where they are engaging in those very unhealthy behaviors like we're going to talk about next, or they're spending lots of time thinking about it. They're engaging in disordered eating in some way to kind of control their weight. And even if they're not, I have some patients who maybe know about eating disorders or have somebody in their life that's experienced an eating disorder. And they're like, I don't want to go down that route. I don't want to be unhealthy or malnourished, but like, I'm still really upset about my body. That's definitely another ball game that we can play in as well. I threw this term in there, orthorexia. This isn't a DSM-5 diagnosis yet, but it is on its way to becoming one, I'm told. And it's that extreme fear of becoming unhealthy and having to control everything to make sure that we are eating healthy, eating clean, organic, whatever kind of thing that is going to keep us healthy, but to a very extreme. We can see significant changes in weight with an eating disorder. This is not a given though. We'll talk about in a minute. The diagnosis of atypical anorexia is actually more typical than normal old anorexia. and the DSM-5 classifies with anorexia that there has to be a certain amount of underweightness, but that does not have to be present for an eating disorder. Someone in a larger body can have an eating disorder as well. All right, and then we've got the impaired functioning, right? So due to whatever behaviors they're engaging in, whether that's restriction or binging and purging, exercising excessively, we can see like laxative or diuretic abuse to try and alter weight, chewing and spitting, anything that they're doing that's impairing their ability to engage in life, right? Or it's causing them to be significantly medically compromised. That definitely falls into eating disorder category there. And then we mentioned extreme dissatisfaction with your body. Thoughts so far here? Does that kind of make sense? Okay, cool. Okay, these are some of the diagnoses. The OSFED one, other specified feeding and eating disorders, is not very well known, but it is kind of the other category, right? And atypical anorexia falls in there. Diabulimia falls in there, which if you've never heard of that before, someone with diabetes is usually withholding their insulin to eat whatever they want. And then if they don't have the insulin so that our body can absorb the carbohydrates and sugars to be used for energy, then those calories are wasted to them. And so it doesn't get absorbed and they can actually lose a lot of weight that way and things like that. But most everybody's heard of anorexia, bulimia, binge eating is now becoming a hot topic. And then we've got ARFID, which doesn't usually fall into the body image world, but there is often a component. I have a patient right now who's very ARFID, has fear of contamination of bugs in her food, really dislikes certain textures or having certain textures be mixed. If she eats a Cheez-It that is like one of the burnt ones, it's just like totally done with Cheez-Its for the next 2 months because I can't stomach it. But she also has issues around her body where she needs to restore weight because of all of these physical symptoms that she has. But she thinks every time I increase her care plan or her meal plan that she can just go and exercise more so that she's turning all of the energy into muscle instead of fat. So there's stuff that overlaps in so many different ways that sometimes the DSM-5 is not adequate enough for diagnoses to be able to capture it all, but this is what we got so far. And then there's lots of co-occurring conditions. We see lots of anxiety and depression and PTSD, trauma, OCD and bipolar, Ehlers-Danlos syndrome, in POTS, the orthostatic tachycardia syndrome, substance abuse, and GI issues, which are so messy. The GI issues are so messy with eating disorders because eating disorders can cause GI issues, but if somebody already has GI issues, it can also cause an eating disorder with the FODMAP diet and things like that too. And there's lots of other co-occurring conditions, but those are probably the most common ones that I see. Okay, so if you've never heard of how to treat someone with an eating disorder, this is your slides here, and I'll kind of run through them quickly just because you can look at this information on your own or even online too. But when I was starting out in eating disorders, the only treatment I knew of was residential. You send them to res and that's it. And I had no idea that there was all of these other levels of care as well. So there is inpatient, right? Like if our person is super medically unstable, maybe there is like fainting going on or significant refeeding syndrome, things like that. They get to go be in the hospital for a while. Sometimes tube feeding is indicated. NG tube is that one that goes from your nose to your stomach, and they give you tube feeding through that. Not super fun for our patients, but if they're not going to eat, that's what they get. And then usually the next level is the residential. They live in a house, there's 24/7 care, there's a doctor and a nurse, a therapist, dietitian, usually psychiatrist in that setting. And they get 3 meals and 3 snacks. They do a bunch of nutrition and therapy groups, and they also have some downtime and they can watch TV and play on their phones and things like that too, depending on where you go. And then there's something called partial hospitalization or PHP. It's kind of misleading. They're really not hospitalized and they're not in 24/7 care. They're usually either virtual or in person. They're usually there for about 6 to 8 hours per day. They get like a lunch, snack, dinner, or a breakfast, snack, lunch, things like that. 2 meals, 1 snack. And they have some more therapy and nutrition groups before they call it a day. And this is kind of that step right, maybe after inpatient or residential, to give them some more freedom, right? They have to cook a couple meals and snacks on their own. They have to do their own grocery shopping. So it's that kind of intermediate of for giving you back some control in your life here. And usually they have a psychiatrist, dietitian, and therapist. At IOP, they just have a therapist and dietitian usually. And then if they needed an outpatient psychiatrist, and of course their primary care and things like that, they can have that there. These people are only there for 3 hours. They get 1 meal in 2 groups, nutrition or therapy groups, and it can be in person or virtual. And this is actually a great option for if you're pretty sure your patient has an eating disorder, you think it's probably not enough to just do outpatient. They need like some really intensive education. Like this would be a great option for them if they're medically stable. And then of course we got our world, right? The outpatient world. At Rooted Path, we see patients about once a week until they feel a little bit more stable and comfortable, and then we can kind of spread those out a little bit. And then, of course, they can be in person or virtual. That's about level of care. If you do not know what level of care your person needs, that is okay. Just getting them hooked up somewhere with, or even having maybe one of your colleagues do an assessment or something like that, just to get some other eyes on the situation can always be helpful. But you can even send them to, doesn't have to be Center for Discovery, but Emily program or any of these other higher level of care places. They always have an admission coordinator that will kind of do like a screen and they can assess what level of care that patient needs too. I have found though that they're not always reliable, I guess. We get lots of patients at Center for Discovery that are not appropriate for a virtual program or not appropriate for that level of care. I'm not trying to say like these programs are like greedy for your patient's money or things like that, but I don't see a lot of people get turned away. That's what I'll say. If they come for an assessment, they're going to put them somewhere in that chain. Instead of saying, oh, you're probably fine, you could just go to outpatient. So just a thought there too. Okay, so these are a couple screening tools I threw in here. These are super fast. So if something that I found is if you think that maybe your patient is showing some disorder eating, you're not quite sure if it's an eating disorder or just something that maybe they could work on in outpatient, these would be a great tool. And I think one of the hardest things is actually like bringing it up with your patient, right? When you hear some of that distressing talk or disordered eating things going on, to actually like breach that line and say, hey, I think we should talk about your eating habits. Like something is just kind of, triggering a red flag in me. I wanted to ask you about your eating because I think maybe you're struggling with some disordered eating. And then seeing if maybe that conversation can come into, hey, why don't we do this screening tool together? There's one on the NIDA website. Let's just do it right now in session together and see if we can kind of open up that conversation, right? Do you guys know maybe what some of the symptoms of like physical symptoms a patient might have when they have an eating disorder? There's quite a lot, but sometimes that's a really good motivator too, to get your patient to see that they're sick. Because sometimes, right, we can say, well, calorie counting is kind of a disordered behavior, or cutting out all of sugar is kind of a disordered behavior, but it's so normalized in our society to do those things that it doesn't really register with them. Like they could just blow you off and say, yeah, maybe, but everybody else is doing it. But if we have some kind of concrete evidence to say like, hey, you told me like you're cold all the time, or you get dizzy when you stand up. Your hair is falling out, your skin is easily bruising, you feel sick all the time, or you get full really easily when you eat. Like those are not normal things, and they can actually be because we're engaging in these behaviors. And what we see a lot is, right, so say somebody cut out all of their sugar and they're coming to you and they're complaining, oh my God, I have all these cravings. This is so hard. I'm still not losing any weight. And so your red flag is triggered there, right? And then all of a sudden they're like, man, I think I need to cut out dairy too. Because every time I eat now, I feel so nauseous and I can only get a couple bites in it. It must be the dairy, right? They're like assigning the next food that could be a problem, or it's gluten, or it's salt, or whatever it could be, right? Instead of realizing, well, this change that you had in your diet is maybe what's caused this in the first place. So if we can roll back the tape a little bit and see what's going on, can maybe take a different path here.
Mhm.
And then, of course, if you're not super comfortable seeing an eating disorder patient, that might be the time when you do your screen, maybe kind of educate them on what you're seeing as disordered behavior and ask if they would be interested in meeting with another therapist or a dietitian or an eating disorder specialist, a psychiatrist, whatever it might be, to get some extra eyes on their case, get some extra help. I've got plenty of patients who work with multiple therapists at once, maybe a trauma therapist who is having trouble with their work because every time they start to dig into something new, restrictive eating gets worse and our patient gets sicker. So then they're like, okay, we can meet on and maybe work through some easier stuff, but you need to see a specialized person to work on your eating while we're doing this. Or we need to stabilize this piece of it and then come back and we'll work on this some more. I don't know how much we want to go through these slides. I just left them in here because I thought it would be kind of interesting for you all. But these are usually what primary care would look at if we were involving them in the care. This is something that you could ask them of your patients too. If you've got eating disorder patients on your caseload, that you would maybe want to recommend they do some weekly screenings, either a blind weight. This doesn't have to be the case though, unless you're really concerned about their need for weight restoration, or more importantly, maybe some orthostatic vitals. And orthostatic means that they're going to lie down for 2 to 5 minutes, and then they're going to take their blood pressure and heart rate, and then they're either going to have them sit or stand, depending on if you're doing like a 3-prong or a 2-prong vitals check here. So they might have them stand up, they time them for another minute, and then they take those vitals again. And if they are dizzy when standing up, or they're feeling a little woozy or maybe even nauseous, and then their heart rate is either jumping up by 30 beats per minute or their blood pressure is tanking when they stand up, that means they've got something going on. And basically it means like their heart is not able to keep up with that change in position. When we stand up, our heart pumps a little bit harder, our blood pressure goes up so that we can get oxygen and blood to our brain, when we were maybe laying down and it was all spread out everywhere. And all of a sudden we're upright and our brain is up here at the top and we have to pump that blood way back up there. So if they're unable to, excuse me, get that blood pumping and their heart working well enough, they're going to pass out if they do that a little too quickly. And that can be one of the things with an eating disorder, is our heart muscle is affected. Body is cannibalizing itself, and if it goes on long enough, it's also eating away at our heart muscle. Your doctor could also request other labs or EKG, a DEXA scan to look at their bone health, things like that. And then, of course, we want to support them in building a team. So if, kind of like we talked about, if they need an ED specialist, a dietitian, a psychiatrist, whatever it is, we want to help and support them in building up this team to really get them the best care. And the other thing we can support with is our language around our folks, right? So avoiding stigmatizing an eating disorder or our patient, right? Things like, you don't look like you have anorexia, or your weight is not low enough, or you just need to eat more, right? Those things are really invalidating, and they can delay care for our patients who maybe were ready to get some help, but all of a sudden it's like, oh no, you're not sick enough. So now I need to get sicker right before I can get help, and they get worse. Instead, we can say things like, yeah, I do think you're sick enough. What you're telling me is concerning, whether it's just disordered eating or whether it may be falling into eating disorder categories. And yeah, we should get you some help. We should get you seen by somebody else, or we should get you in with an admissions coordinator at X, Y, and Z facility, whatever it is. Okay, through some resources on here. There are so many resources out there. I could not squeeze them all on here. I will give you these slides, of course, and you can dig into some books and some podcasts if that's more your speed. Before I maybe go into that, though, let's go back and talk about some of those other questions that came up in the beginning. Um, there's questions about like what a session might look like with a dietitian. So when they sit down with us, we go through a pretty intense hour of kind of their history, what maybe their even their childhood or upbringing looks like around food, and what kind of body talk. We talk about what their eating is like now, as far as like maybe how much they're eating in the day. Is it all concentrated to dinner time or is it spread out throughout the day? We'll do an assessment to make sure we think it's at least meeting their, what do you call it, their BMR, their basal metabolic rate. Um, but oftentimes, we get through the session, we talk about symptoms and other behaviors and things like that. And the session usually goes, okay, I don't think you're eating enough. And then we talk about that. And I don't always prescribe a meal plan. It really depends on the patient and where they're at and what tools they would like to use. But we talk about, what are their goals? How are we going to get there? So maybe not meal plan. We definitely talk about food exposures for patients who feel like there are certain foods that are scary for them to eat, whether that means this food's going to make me gain weight or I'm going to binge on it or whatever it is. Um, and then when we meet weekly for sessions, we kind of start peeling apart those layers, right? We do the education on diet culture and weight stigma. We talk about the restored binge cycle. We talk about intuitive eating and getting more in touch with their hunger and fullness cues. Talk about creating satisfaction in their eating and joy. Setting boundaries is a big one, especially with loved ones or other people they might live with that do want to engage in body shaming talk or demonizing of food. And so, how do we set some boundaries with those folks? We are a big advocate in the medical fields with their primary care or hepatologist or GI doctor or whoever it is that is maybe also saying, well, just lose weight and your problems will get better. And so we cross that bridge and do that coordination of care to talk about how maybe it's contraindicated for your binge eating patient to lose weight right now because they're finally in a spot where they're not binging every day. And if the weight loss comes naturally, cool, but also their binge eating stopping is also going to be helpful for their GI health or their liver or whatever it is. So trying to do some education in our community too from that aspect. So hopefully that kind of answers that question and maybe can help calm nerves of a patient who's never talked to a dietitian or anybody about their eating disorder before. What other questions did I miss as we went throughout this?
I'm curious from your perspective, knowing that dissociation can be such a major component of an eating disorder. Do you find it's hard to, be in these conversations with someone around the actual food element of their life, and then they're off in the world for the week and the implementation of it? Like, what's that like for you, and what do you see, and how can we support that as therapists, maybe in a way we haven't thought of?
Sure. Yeah, the coordination that I do with therapists is so key. Because you're right, like one, it's very activating to talk about food or body image for an hour in session and then send them off to go try and eat more or whatever it is that they need to do. Um, so we talk about coping skills, like if they don't have a therapist or somebody that they've ever talked to about other skills that they can use, we will, I love my DBT and my CBT skills. We'll talk about TIP, talk about the stop skill, talk about finding our fact-checking voice and things like that, and teasing out eating disorder versus wise mind voice. But I would love the help if if they have a therapist. I'm asking the therapist, can you please teach them these skills in session, because they're not able to cope or to ground or whatever it is on their own right now. And so having those skills, and we recognize they're not fun to practice these skills. It is actually work. So we talk about like practicing them. If maybe we're not super activated, can we try some deep breathing just normally when we're sitting, waiting for a meeting to start or whatever it is, to get some of those skills under their belt. But yeah, it is challenging, especially at the start, to begin practicing some of those skills and get them really motivated and committed to trying a different way of practicing this relating to eating. Yeah, Amanda.
Yeah, thank you. This is like, I don't have like an exact question in mind, but kind of I last night got an email from like Evergreen Wellness that I, got a like blood draw from them a long time ago. Now I get their stuff. And it was a whole article about intermittent fasting
Oh,
and
geez.
written by a dietitian. And I like I had to read it. I don't know. I was like a masochist. I was like, I have to read what this says. And yeah, one of the like things in there was like, who is this not recommended for? Somebody who has an eating disorder. But then, continued to talk about, the different types of fasting. You could do like a 24-hour fast or a 16-hour fast. And I don't know, I have this conversation a lot with clients about how even within dietary world, like there is still such a divide. And
Yeah.
we know that it's like provider by provider at times. So intermittent fasting has become such like a hot button thing that people are doing. So I'm curious, like your perspective there, how you maybe start talking to clients about intermittent fasting. And then maybe a little bit of like why there's such a divide even within dietary world and medical world, and like why there's this polarizing kind of thing happening.
Totally. Oh my gosh. And yeah, I can give you my perspective there, but I do not have all the answers. But as far as intermittent fasting, there's even like research coming out this week that's like, especially for women, it increases cardiovascular risk. So I'm glad that there's like some negative feedback coming out and research coming out about it to maybe deter people. But we kind of bring it back to like intuitive eating and how we do naturally fast overnight when we're asleep, and our body doesn't need any more help. It can do its thing and fast on its own. But when we are purposefully ignoring a hunger cue, maybe a hunger cue comes at like 9 a.m. or something like that, and we say, no, I can't eat until 12, we're ignoring our body's ask for food, right? It is asking for energy. And we are saying, nope, I have this thing I'm doing. And our body's like, well, what the heck? Like my cells need energy. I am hungry. And our even though we can see that there's enough food with our eyes, right? The refrigerator's full, the cupboards are full, that doesn't matter to our body, right? We're inducing this, I don't know, people call it starvation mode or restrictive mode in our body. And our body doesn't know the difference. And so as a result, it's doing its own cascade of systems, right? It's reducing our metabolism so that it can conserve energy. It's turning down the heat so we feel maybe a little bit more cold, whatever it is. And so that's kind of the route that I go with my patients when we talk about that is our bodies are designed to fast, and that's good for them. Like they can do that, but we don't need to take over that control. It's not adding to our health to do it for just a little bit longer. What's detracting from our health is ignoring our hunger cues. As far as the divide, it's so vast. Like I started out in weight loss. That was my first job that I got as a dietitian. I counseled for bariatric surgery, and I never heard of health at every size. I'd actually heard of intuitive eating, but it was in college and it was in the middle of, the most intense coursework I'd ever had. And so there was no time for me to read an extra book for fun. And we ended up doing like a lunch and learn kind of thing in the middle of this weight loss group. And we read Intuitive Eating and we read Health at Every Size. And it totally explained why my patients were, one, not losing weight, but two, like why they had all of these intense feelings about food and their bodies. And they would come in and be crying in my office about how they didn't lose the weight that they wanted. And it was so distressing for me. I didn't know how to help them at that point, right? Because you can give them all the advice in the world, but we weren't told in school that there is like very little chance that somebody can lose weight and keep it off, and that it gets harder every time you go through the weight loss process to lose the weight. And so, right, we're just told like, no, you should be able to do it. You can control your health. And that's the world that we live in. The research by Catherine Flegel about, morbidity rates and BMI is so underappreciated, even though there's 95 other studies before she did hers, published one in 2013, that also supports that it doesn't matter what the BMI says, only people at the very extremes on sizes are at risk for early death. So it's like all of these things that are really tamped down and hidden in any medical setting. It's hard to combat, right? And so you're right, when we see those kind of articles and when our patients see articles like that or other information on the news, it's hard not to take it at face value. And until you actually look at the research and the way that we look at our medical industry, it's a lot of work to unlearn all of that stuff. I think that's why there's that divide. It's so hidden. Did you guys see, I think it was maybe last year around this time, the Academy of Nutrition and Dietetics, kind of like our organization for RDs, they put out this, they call it like an evidence-based treatment plan or something like that for people with obesity. I use that word in quotes. And basically they had said like that Health at Every Size was bullshit and that nobody should follow it. And they got this huge whiplash response, especially from the eating disorder community, because they had put it out for everybody to kind of like give feedback on. And thankfully they had said like, okay, like we'll go back and revise it. But they were saying like, just eat 1,200 calories a day, everybody. And like, no, like we will not let you take that stand. Like as half of the dietitians in the dietitian community, like no way are we going to say that's okay for you to put out there to the world. It was so disheartening. Okay, how about Ozempic? How many of your patients do you see on Ozempic? My goodness. There's a new one out there, like Zepbound too, that I'm seeing. I don't know as much about that one. But it's hard because those GLP-1 drugs are messing with our patients' GI tracts and their hunger and fullness cues, which is why they're effective for weight loss, right? They might bring down somebody's blood sugar if they have diabetes, but they're also like Adderall or any other kind of stimulant. They're also like suppressing this person's appetite. And so they're eating less and they're losing weight. But if they come off the medication, their appetite comes back. So then it's being touted as something you have to stay on forever. And if you don't have diabetes, you can't get Ozempic. You can only get Wegovy, which is not covered by insurance and is hundreds of dollars every month. And oh, it's a big mess. Such a mess. And I think too, like
Hey,
our
Brandy, I
patients.
have a question.
Yeah, go for it.
So going back to the BMI, right? And like, growing up, I know in my age, like growing up when it was always stressed about. And even the food pyramid, I learned in school, like, you know, that traditional food pyramid. And I see a lot of people my age, like in their 30s, and 40s. And so how do you talk to clients like getting that, because now BMI, they're like, oh, it's not really to follow. And these are just like average people. It's not, I don't work with anybody like uh you know, too bad. But how do you like, how do you have that mental shift? What do you do like to take them like, okay, that BMI really doesn't matter, or like talking to your doctor, and sometimes doctors are not as empathetic as us therapists. So like, how do we change that mind shift, or how do we not change that mind shift, but how do we educate our clients in that aspect when they've grown up with the BMI chart, I guess?
Totally. And this was such a fun thing for me to learn as well. But I think probably the biggest part in educating our patients is to talk about why it's not for them, right? Like we can see things in a general terms, but if we can get it to apply back to them, that'll be the best part, right? So um, BMI is not only racist, but a sexist tool, and was created back in the 1800s by not a doctor, not a scientist, but a mathematician, right? Adolphe Quetelet. And and just having that kind of education with our patients of like, this was not intended to diagnose your medical conditions. And when Ansel Keys did his research, it wasn't necessarily to diagnose medical conditions. It was to assess, like a tool to assess someone's body fat percentage compared to skin calipers and other measurements as well. And that, it was for life insurance companies. They wanted a tool to be able to charge more money to people who were fatter. It used to be different, right? Those ranges that we have now were changed back in 1998, I believe, at the NIH conference, against the research that said, actually, we shouldn't be changing these BMI numbers. Like people in, what was it at the time? Like the 25 to 27 were like the normal categories, and they were different for both men and women. Like they weren't at any higher risk of disease or death. And so when we changed them and we lowered all those numbers, overnight, everybody became overweight or obese or whatever we want to call it. And none of their health conditions changed, right? We just automatically assigned that disease to them. And that obesity or overweight or whatever we want to call it is the only disease out there that's based on a number and not any other physical criteria, right? If we look at high blood pressure, there is specific criteria to say over 2 visits, you have to be over this systolic and diastolic, and then you can get diagnosed. But BMI, you come in, they take your weight and your height, and automatically you have obesity, right? So there is a great YouTube video out there that actually is a 3-part series that I've shown to patients before. I think it's by, the handle is like okay to be fat. And I think it's maybe like the history of the BMI or something like that. So if you do not have time to like go in depth in your sessions about the history, maybe that's some good homework for them. Even just the second video in the series is probably the best one. But yeah, having that education point, if they're willing, right? We can't force and make them listen. But if we can plant the little seed that says, hey, you might be assigning a little bit too much value here, and it's eating up your time and your life and your money, even if you're spending money on drugs or weight loss drugs or gyms or whatever it might be. Why don't you go watch this video and then let's come back and talk about it and see what this education means to you. It's kind of a long-winded answer, sorry.
No, it's wonderful. Thank you so much.
I know Maintenance Phase, the podcast you have here, has a whole episode on that. And it's sad but hysterical. Like yeah, it's a fun, I think someone who maybe is just entering this conversation, Amisha, would find it kind of entertaining enough that they could, also digest the information. So.
Absolutely. I will put a caveat that there is a lot of swearing, especially in the earlier episodes. But so if your patient's not okay with like excessive F word use, then
Good point.
different one. But yeah, Maintenance Phase has so many great episodes in there. They address like obesity. They've addressed like the trouble with calories, I think is one of their episodes, to talk about why just counting calories is stupid, or why having them on a label for our food is so irrelevant and so helpful.
I did have kind of like a connecting question to Amisha. I recently ran into this that like it's really actually hard to find nutritional information that doesn't have like a bias of some kind to it. Do you perhaps like have any resources or place that you usually like point people to, like what every meal should like try to have, like how often you should be eating, like
Oh,
those kind of stats or guidelines perhaps?
good question. And it makes me think too, like why maybe there isn't that kind of resource out there. I'm just thinking like it's so individualized. But yeah, there's plenty out there that's like you should start eating within an hour of waking up and you should have this many meals or snacks in the day, or you shouldn't have any snacks in the day, whatever it is. There's so much like conflicting evidence that I think that's probably why maybe either like our blog or other eating disorder or disordered eating informed blogs don't contain really specifics like that, just because we want everybody to find their own normal and their own balance for their bodies, and there's not a cookie cutter answer. But eating enough is probably a bigger resource that we could point to, right? Of saying like doesn't matter when you eat or how much you eat at one time, as long as your body's getting enough, we're honoring those hunger and fullness cues. We feel satisfied when we're eating, we have enough energy during the day. Those are kind of our clues, right?
Do you how do you talk with clients about the process of like starting to increase their intake when they've been restricting a long time and their appetite's really suppressed? So like, yes, that's the end goal, to get them where they can tune into themselves, but there is this process of waking their digestive system up again. And I often find like my clients start to push back, like I'm full, like I'm listening to my body. Like how do you support them through that process?
Yeah, totally. Um, if it's been assessed that yes, like they're not eating enough, maybe they're eating one meal a day or something like that. Um, that that question of how do we get them to eat more, we have to get their buy-in first, right? Like we have to kind of maybe pinpoint their pain points of like, well, you don't have enough energy, or we're looking at the physical symptoms again, or we're having a lot of GI distress, and maybe we can help that with incorporating more eating again. So whatever their buy-in point is, that's kind of where we start. Um, I'm pretty blunt with my patients. There have been a couple times where I've maybe been a little bit more reserved, but I'm pretty blunt about like if I think they need to restore weight or not, whether they're in a bigger body or not. There's definitely symptoms that point to maybe somebody being weight suppressed and that being an impact on their life. And so that can also come into the conversation of, I think we need to eat more because we're having these symptoms because you're weight suppressed, whatever the buy-in is. We then talk about how they can't practice intuitive eating, even though it sounds wonderful and they want to be able to follow their body. We really can't practice intuitive eating until we're at that point where we're eating enough consistently over the long term. And it takes your body a long time to recover from nutrition trauma. We don't think about it that way. We just think about it as dieting or whatever we want to call it, but it is a trauma to our body. So showing up for our body and telling it, I'm going to feed you consistently over the day, and I'm going to meet your hunger cues whenever they pop up over and over and over for weeks and months and however long it takes. Um, that's when we can start getting those regular hunger cues again. And so until then, we talk about mechanical eating, um, eating when we're not hungry, because we kind of know we have to start somewhere. And even though it's really not comfortable and can sometimes like induce nausea, um, there's maybe like an element of gastroparesis going on where our stomach isn't emptying and we're getting full after a couple bites. Seeing how much we can push our person, our patient, and help them to tolerate that distress, which is another area where you guys come in, right? It is distressing to try and eat more, let alone try and eat when you're not hungry or when it doesn't feel good. So how do we sit with that distress and build a tolerance? And even if it's just having 3 more bites after we feel full for the first couple days, and then 4 more bites or whatever it is, just something little to get a little bit more nutrition in there. And like you said, Shannon, wake up the GI system, wake up those hunger cues again. And then a lot of times I see once it is woken up, there's big hunger cues. So things get really intense then and distressing as well, because what if this never goes away? What if I just keep eating forever and ever and I gain 500 pounds? Well, that's probably not practical or logical, right? So we can kind of address that. But yeah, how do we get through that kind of period? Because it is going to balance out, it's going to get better, but sometimes it takes a couple weeks or a month or two for that to settle down again. So there's lots of shifts and changes that go on in the body in recovery. It's very scary, very distressing for them.
Yeah, thanks for bringing up that last piece of the swing of the increase in hunger and how terrifying that is for clients. And so I think for us, it's a lot of like, this is normal, this is right, this is your body trying to catch up. Yeah. I sometimes, it took me a while to remember to bring that up with my clients so they weren't like, because they get terrified and sometimes would bolt as soon as their hunger came back. Yeah, I'm glad you named that.
Absolutely. So I remember somebody had asked about weight stigma and how do we kind of have those conversations. I had alluded a little bit to kind of the different levels. There's 3 different levels of weight stigma that a person can experience. And a lot of times we just start to name it. Like, hey, I hear you, talking about this aspect or this belief or whatever it is. And I'm just going to call you out right now. Like that's some fat phobia going on, or that's your internalized weight stigma. And they're kind of like, oh, so let's talk about that. Like, what stigmas do we have about people in bigger bodies? And what did you grow up believing, or what did family or parents or teachers or whoever tell you about bodies? I know, and to share your own experience too. For me, like half my family was always dieting, and whenever we would get together, oh, you're drinking light beer? I like this one, and I'm on this diet, and I lost this much weight, right? And there was this fear of, well, I gotta be careful and not ever let myself get to that point. Or if I get to that point, I'm gonna have to do what they're doing. And it was scary as a kid, even 10 years old, to have those messages start to filter in. I didn't have social media like we have it now, but it's even worse now with social media. So kind of naming it, and I've heard so much feedback from the kiddos at Center for Discovery when we talk about the research on weight stigma and how it increases our cortisol levels, and how that's probably one of the main reasons why we see people in bigger body seem to have like more health issues or more extreme health issues. And it's the stigma that, well, they just don't go to the doctor. They hate being told, well, just lose weight and you'll feel better, or not being properly treated and tested. And so they just don't go until their problems get so bad that they can't stand it anymore. And by then, right, everything is worsened. And the kids are just like, why don't they teach us this in health class? I'm like, yeah, man, I don't know, because it doesn't make sense to me either. But yeah, having those conversations and actually looking at the research can be really helpful. Doesn't fix a whole lot because we know education isn't everything, but it's a good starting place to get them mad, right? It is a grieving process. And if we can get them mad about the cat's changing things, about how things are treated in our world, then we can start to address it right. They don't like knowing that even if that is all true, what if people still treat me like poop, right? Like, even if I'm in a bigger body and I am okay with my own body, people are still going to treat me bad. And so then how do we tease apart that and set the boundaries and work on our self-care and get the people in our corner that are going to help bring us support, and maybe come to the doctor's appointment with you when you're all choked up and maybe about to cry because somebody's stigmatizing you, and have somebody be there and help speak up for you. So yeah, there's a lot of different aspects that we can help build our patients up with. Other thoughts or questions before we start to wrap up? I know it's 12. I talked the whole time, guys.
Anything else anyone wanted to ask or share? Well, Brandy, thank you so much. I mean, this is incredible. I think Shannon said it well, of just, it feels so good to be having this as a conversation as a team and something that's at the front of our minds, just knowing how many of our, I mean, every client is somehow impacted in some, whether it's them or a family, somebody, so, or just the culture we're in. So, it just feels really helpful. And thanks for the work you're doing. I mean, it sounds like, you and Rooted Path just do incredible, incredible service for your clients. So happy you're here.
Thanks. Thank you. Thank you. Yeah, I'm so excited that we get to coordinate more together. It's
I
wonderful.
know. Well, and will you share this, the presentation, the slides with me as well? So we can, guys, when I send out the recording, I will share the slides as well. So you have all the resources that you added in here. So,
Perfect.
um,
All right. Well, we'll talk soon.
hey,
Have a
thank
great
you so much,
day.
Brandy.
Thank you.
Okay, bye-bye.
Thank you.